Now it is.
Pardon me.
All right.
Okay.
Come on, Luna.
Well, good afternoon, good morning, good evening. My name's Donnie. I'm a respiratory therapist. I've been working in the Central Florida area around Tampa Bay for 26 years. And today we're going to cover tracheotomy. First, I'm going to start off with the history. The first tracheotomy is believed to have been conducted by an Egyptian 3,600 years ago, before Christ or before the Common Era, depending on what you've been taught. Hippocrates was condemned. There was concern because they thought that he would sever the carotid artery and the patient would die. Later on, an ancient Roman, Cephides, a doctor in the 2nd century, is credited as having performed the first non-emergent tracheotomy. Then a little later on, in 1620, a French doctor, Nicolas Habakkuk, recorded the first case that a tracheotomy was performed in order to remove a foreign body. Interestingly enough, this foreign body ended up being a blood clot on a stabbing victim. So he actually did it on a trauma patient. In 1820, a doctor was recognized as doing a tracheotomy to treat severe airway obstruction. And the current tracheotomy technique was first described by Cavalier Jackson of Pittsburgh, Pennsylvania, in the early 1900s, about 1909, 1910, I believe. Tracheotomies are performed either in the operating room or today, depending on your facility and your doctors, you might do what's called a percutaneous trach, and that can be performed in the bed at bedside, as a surgeon is performing a incision on the neck. Another doctor, usually pulmonary or an intensivist, is watching the procedure through the vocal cords with a bronchoscope, and your job is to unsecure the airway as a respiratory therapist and hold that airway, the ET tube, until the cartilage has been dilated, and the surgeon pops the tracheotomy in between two cartilage. And once the pulmonologist observes this being done with the bronchoscope, he or she will tell you or instruct you to remove the ET tube. There's a couple of advantages of the percutaneous trach this way. The doctor can observe the procedure and ensure the safety of the patient by making sure that the tracheostomy tube is not perforating the back side of the trachea. And also they can suction the blood out as well. A perc trach was the procedure itself. Dr. Segalia came up with the technique, and the technique that most people know by this physician is called the Blue Rhino technique. It's a kit, and it has up to 7 dilators, and you have a small one. And once they first pop in to the neck, it's a small dilator, and pulls it out, and then puts the next one in, which is the next size. And you can go up to 7 sizes depending on the size tracheostomy that the doctor wants in the patient. Dr. Griggs came up with a forceps to create a central hole and a guide wire, and then the dilatation is done with a single step by the actual trach that they're inserting, and they just pop it in between the two cartilage of the neck, and you'll actually hear it pop. Okay? So, indications for a tracheostomy. Long-term ventilation. Usually the patient will have a endotracheal tube in place anywhere from 10 to 14 days. A consult will be done, and they'll have the family members or the patient themselves sign the consent, and then the procedure is performed. When this is not done, it's usually an emergent procedure, and it's usually in ER that it's emergently done, and it's usually because of an upper airway obstruction. Advantages to a trach is it's easy to stabilize. It allows suctioning of the airway, providing airway clearance and reduction of airway resistance by getting rid of the sputum. It allows for specimen collection, so we can send it off to the lab and identify the microorganisms causing pneumonia, so that antibiotic therapy can become more specific instead of a general antibiotic. The patient tolerates weaning real quick. It also prevents sores to the lips, which can be a source of infection, especially if we haven't rotated the ET tube from one side to the other side or to the middle. They get a sore on their lip. It allows the patient to eat, which is a big morale boost for the patient, because the whole time that they're on the ET tube, you don't get to eat, so your taste buds aren't being used, and it's a big morale boost. Patients love to eat. It's a normal function of their life, so it's also a mental boost as well. I'm getting some control back. I'm starting to come back to a normal function of life, and we also can help them get the passing mirror valve put in line or onto the trach itself, and that allows for speaking, and that's another morale boost, because now I'm getting control of my life back. I can tell you what I know, like, not like, and anything in between. Alright, so complications of a tracheostomy. You can have infection at the site if not properly cleaned. Most hospitals in the Bay Area have you clean it once a shift and PRN as necessary. Let's see. Recently had a trach that was bleeding, so sometimes ENT or the surgeon themselves will come in, and what they'll do is they'll put packing around the back side of a trach, behind the flange, just inside the stoma, or they'll cauterize it. There's a stick, I forget the chemical name right now, but it helps cauterize some bleeding. Complication, you could have a pneumothorax, hemothorax, air emboli, sub-Q emphysema. So hemorrhage is the big one though. Sometimes you have long-term stenosis, and then there's always the one that all the hospitals are tracking right now. It's the self-extubation / dislodgement, and this usually happens during the bath or transfer from the bed to the chair. Mobility has become a big part of the plan of taking care of long-term trach patients and ET tube patients. So sometimes when they go from the bed to the chair, the tubing might get caught on the arm of the chair or the rail of the bed and just pulls the tube right out. Some of the later complications greater than 48 hours would be infection, hemorrhage, obstruction, and TE fistula. So let's go over the anatomy of a trach. I just happen to have one here. And a lot of the Bay Area uses Shiley, but there's also Pravona. The big difference between a Shiley and the Pravona is that the Pravona uses a foam cuff, and the atmospheric air inflates that one. And then you have the XLT, it's usually blue, and the key to the XLT is you have proximal to the front part of the airway and distal to the airway. So your doctors will be specifying which one they want to insert depending on the anatomy of the patient, and so you always want to double check your box. Now, I just happen to have a Shiley. Sorry, it's backwards. Okay, and it'll say cuffed or cuffless. Okay, and the size is always on the front of the box. This is a 6 DCT. Now, the thing about trachs in terms of Shiley is DCT versus LPC. DCT is a disposable inner cannula. And what will happen is your hospital and company will order the inner cannulas, and when you go to do your trach care, which is usually Q12 hours or as needed, and you'll just replace the one and put in a new one. Whereas the LPC on the hub, it'll have a blue dot and it interlocks, and you'll know it interlock because the two blue dots will line up and you'll feel a snap. Okay, so let's go ahead and open this up. Alright, so I know it's not the best, but this is what it'll look like when you first get it. So let's say you're going from an 8, because respiratory therapists and doctors will wean the trach as well as the ventilator. After they get on to the trach collar, they'll order a downsizing, and it's usually from a cuff to an uncuff to allow better phonation during speaking with the passenger valve, better swallowing because the cuff inside the trachea, by being eliminated by putting the cuffless in, the patient can eat better. Now, this usually involves a swallow study, and depending on which hospital you work at, you'll attend the swallow study depending on if they do it while they're still on the ventilator or after they've been put on the trach collar. So, opening this up, okay, you have the obturator, okay, and that goes inside the inside of the trach when you go to change it. And the way that works, you'll make sure that, okay, alright, here we go, that the pilot balloon out here is deflated, and it is. You'll take the inner cannula. Now, the DCT is an alligator clip. You squeeze it and you pull it out. When you put the new one in, you push it till it clips. Now, what I do is I'll hold the flange, okay, and the flange, by doing that, it doesn't move around making the patient cough. Now, where this is really important is when the patient has a lot of secretions. You don't want to get sputumized with their secretions. I suggest you wear a mask, goggles, and gown and gloves when you do this, because if they have a lot of secretions, it's going to get on your arm or hand if you don't suction before the procedure of changing the trach. Now, right here is the flange, and as you can see, the 6 DCT, 6 disposable. That's the size. Okay? Once the doctor puts it in the patient, this is what it looks like. Okay? And then when you take your syringe, after inserting the new one, the cuff will blow up. As you can see, inside this picture, it'll seal the airway. Okay, sorry about that. Now, I use a 10 cc syringe, okay, and what I do is I have it to the side. When I go to do this, I put the obturator in. Now, the obturator, the whole purpose of an obturator, see how it's blunt? Once you put it inside the trachea, you don't want to scratch the inside lumen of the trachea. Whereas if you just do without the obturator, It's a sharp edge. Okay, so it's for patient safety. Now when you pop it in, right, you put it in the neck, they cough. And this will pop up some. You just pull this out and hold the flange. Now there usually is a minor bit of bleeding when you first put it in. It's trauma to the outer dermis, or just inside the stoma of the trachea. That's normal. But if you have profuse bleeding, monitor it. If it continues to where you're constantly having to deal with it, you need to notify your physician and your nurse. Okay, and then once you do that, you put the strap around the neck. We use the Velcro type now. You do have an old tie, but nobody uses them anymore. And the Velcro strap just goes through the two slots, and it just folds over. And then you put a gauze up underneath. Okay, and then you put your inner cannula in. Now, some places, when you change airways, they'll want you to get an ETCO2 detector and make sure you have change of color. And when you chart the change of the trach, you want to make sure you chart bilateral breath sounds. And you also want to chart the SpO2. Regardless of FiO2, you want to chart that to show that they are oxygenating afterwards. Cleaning a trach with a DCT, you pretty much throw this one away, put a new one in. With the LPC, you have a kit, and I'll cover that in another lesson. Alrighty, so what else have we got here? Alright. Okay. You have a fenestrated trach.